I think this is talk number 7 in the last 5 working days. So excuse me if I get a bit confused about what's next and where I'm supposed to be. I don't even know how long I'm supposed to talk for. Can you remind me?
Up to 30 minutes.
All right. All right, so just let me know if you're getting bored. If I see the eyes glazing over, I'll change gears and talk about my kids or something. Okay, so that's me. And thank you for having me. It's been a whirlwind. Before I dive in, a little bit more about me and a little bit just for context I think is useful. Maybe it won't work. Urgent help. What do I do? How do I make it go?
If you use the mouse.
All right. Did that work? Yeah. All right. Cool.
And now
So,
it should be okay to use that.
Yeah. All right. So I'm a physician, and for better and for worse, that colors my way of thinking. In particular, I'm a family doc. And so if we start talking about, things that family docs don't see, I may not be able to contribute a lot to the conversation. And if we want to start talking about the roles of nurses and stuff like that, we can. I just won't have a lot to contribute. I'm Canadian, also for better and for worse. And so we have this opportunity to, we have really great linked database in the province where I'm from. And it's hard, I think we have to have a conversation about the resources that we do have or don't have here in comparison. And lastly, with the interventions that I design and the trials that I do, very much I stand on the shoulders of giants, and I've really benefited from amazing mentorship, including Karen along the way. So just trying to channel their thoughts mainly. If you don't know, that's where Toronto is. It's one of the reasons I sound American, I suppose. We're sort of right in there in the States. When I'm in the States, I often show this so that people know, but I assume Australians kind of know where Toronto is, so that's good. If we zoom in a little bit, you can see the hospital where Karen is, Toronto Western Hospital. You see my hospital in red, Women's College. You see my house, it's a little blue arrow there. And so that's sort of a sense of what things look like. This is our group at Women's College Hospital. It's got a terrible acronym. WEAV stands for Women's College Hospital Institute for Health System Solutions and Virtual Care. I dare you to say that 3 times fast. It's a great group, and we get to do some innovative stuff. We really focus on, large-scale interventions and policy and things like this. It's very fun. And this is the group that I lead within that larger group. And we have a lot of fun together. I'm really blessed to work with really bright people who all come to work with a shared mission of trying to, improve quality of care. And improving quality of care is super complicated. And so it's fun to think through the challenges. So if you want to come to Canada and join our group, you'll be forced to design a Bitmoji. Just warning you. And then when I'm not at work, this is what my life kind of looks like. It's a lot of time at hockey rinks nowadays. And in the summer, it's a lot of time by a lake and at camp and stuff like that. So that's sort of me in a nutshell. It gives you a bit of context. And now we'll talk about, I think, what I'm meant to talk about. Okay, so you guys already know this, but most antibiotic prescribing, human antibiotic prescribing, is not in hospital. And it's a good reason why you have 2 family docs here, or GPs as you guys call them. Most antibiotics are prescribed in the community. So we really have to think about antimicrobial stewardship in the community, not just in hospital, where traditionally it's been focused. And so with that in mind, there's actually been more and more folks trying to improve antibiotic prescribing, as you know, out in the community. There's been a whole series of trials looking at this. We're going to talk about basically each of these. They have a fair bit of overlap. Most of them have shown a benefit. The basic idea is that in many jurisdictions, groups have gotten together and used existing data sources to contact prescribers and say, hey, community-based prescriber, stop prescribing so much. That's the common thread of all these interventions. How exactly they identify the prescribers, how exactly they give that message to say, stop doing that. It's all a little bit different, and we'll talk about that now. All right, so this is Jeff Linder's work in the States. What you see with this is some interesting things. He compared sort of different ways of delivering the message. In one instance, he compared people to similar peers and their practices in terms of antibiotic prescribing, and that's the aspect of the trial where they saw the greatest impact for their intervention. Okay, cool. So we have a sense based on this that if we're going to give information out to prescribers, we should compare them to their peers. I can talk at length about that from other evidence as well, if you like. The other bits of content they tried to include or not include in there didn't nearly make as much difference. Hold on. There we go. That's the peer comparison. The thing they did that was kind of interesting is that they said, hey, you're no good. Basically, they were quite harsh with their text. And I don't think I would recommend that for long-term quality improvement. But you are going to get some movement if you are harsh, I think. So otherwise, people get this sense that, oh, well, you know, you're great or you're not great. And this is sort of what it basically looked like. It looked like an email said, you know, there's room for improvement here. And so if it were possible here to send emails saying, hi, you're either in the best group of prescribers or you're not, there's some evidence from the literature that that would make a difference. Maybe we try a different jurisdiction. So this is a big trial that was published in The Lancet. What happened was they sent a letter, interestingly, co-signed by a well-known opinion leader. So this is a chief medical officer, sort of everybody kind of in the jurisdiction knows who Sally Davies is, and kind of when she signs something, it's not like Noah Ivers signed something. They like actually know who she is. They care whether she thinks positively about them. So that seemed to have a little bit of a difference. Interestingly, they only sent the letter to those who needed to get it. So they reached out to people who the data suggested were outliers in their prescribing practice. And, you know, basically this well-respected woman signed a letter saying, you know, you're an outlier. So a bit of a common thread we're seeing here. And then the thing I want to highlight about this study is that you see the chart there, it looks like a very small difference. But we're talking about thousands of prescriptions. So small differences in a population scale for antibiotics can make a big difference. We're talking about 73,000 less antibiotic prescriptions from a letter. I mean, that's pretty spectacular. I think that's partly why it ended up in The Lancet. More important than ending up in The Lancet, of course, is that they actually made an impact that appears to be sustained. There's been some follow-up studies. It appears to have been sustained for those outlier prescribers. Now, I showed you that chart before. It is fair to say that it doesn't always work to send a letter. In Switzerland, they sent something slightly fancier. It wasn't just a basic text letter from a well-known opinion leader. It was a notification with all sorts of metrics, as you can see on the left there, telling people about their prescribing. And in fact, this didn't work. By which I mean there was no statistically significant difference between the control group and the intervention group. My best sense of why that is that the message got lost in the noise. There's a whole bunch of metrics there, as opposed to just, if we think about Jeff Linder's study, if we think about the study in the UK, it was a very clear single message. You're an outlier, stop prescribing so much. Whereas here it's like, it's just kind of, well, what's the message? So with that in mind, it gives some context to what was done, to my understanding, fairly recently here in Australia. So they kind of copied the idea of the Lancet paper that I talked about, sending a letter. They strangely added these little figure with the pills. I don't really get that. But, you know, basically trying to tell people that they're an outlier. And then they tested different ways of communicating the message to get the signal through the noise. So one can simply give education saying, hey, antimicrobial stewardship is important. One can say, hey, you're an outlier with the peer comparison. One can give the peer comparison and give an action plan saying, you might want to try something like delayed prescribing that works. And maybe you might want to give some sort of figure like this pills. I don't really get it, but turns out the pills kind of worked. And so each of the different ways of communicating this content made a slightly different difference. This, to my knowledge, has not been peer-reviewed or published in a peer-reviewed journal. We found it on a Google search, Greylit search. But it's kind of intriguing. It suggests that that the way that we communicate the information really, really matters. All right. One more study. I'm gonna skip this one, but just so you know, there's a very recent one in the BMJ. It worked, just to highlight that it worked particularly in some age subgroups and not as well in others. I don't want to spend too much time on that. We can come back to it if you want, just cognizant of time. So all this can be thought of in the context of lots and lots and lots of work that's been done in the literature around audit and feedback. So audit and feedback is any intervention where we summarize quality of care and give it back to the healthcare professionals responsible for that care in the hopes that it'll encourage quality improvement, yeah? And what we know from the literature is that we're not learning rapidly how to get the most out of our audit and feedback interventions, in large part because we keep trialing audit and feedback against control. And we've tried to make a very clear argument in the literature more recently that we don't need any more studies of audit and feedback versus control. What we need is studies like the one here in Australia that compare different ways of delivering the audit and feedback. That's what's going to add to the literature and help us hopefully move the median effect size of audit and feedback interventions towards a larger end of the spectrum. Because right now we're learning very slowly. I have to make sense of all these different studies that compared against control and indirectly compare what was better about them and so on. It would be better if moving forward we actually had multiple comparisons within our trial. So locally in Ontario, we're trying to do some things of that nature. That's Nick Daneman, very nice infectious disease physician. And he's helped lead a study that we've done along with Health Quality Ontario in our jurisdiction, where we give feedback to physicians working in nursing homes, old age homes. Yeah, I keep forgetting what you guys call it. Is that right? Yeah, aged care homes. It's close. In that setting, the physicians can sign up for a static report like this one, or when they sign up, they might be randomized to get a more interactive dashboardy kind of thing that tries to address some of the common issues that arise when you give physicians data about their practice. Have any of you gotten data about your practice? Yeah, none of you? Well, that's sad. Joanne, what do you say when you get data about your practice and it tells you that you're not doing so well?
Well.
What do you say? Come on, I know what you say. You say the data's no good. You say the data's no good, and then if the data is good, you say something like, yeah, but my patients are different and you didn't account for that. That is what you'll say, right? You know you will. So the goal of the intervention that Nick designed is to address those sort of predictable defensive reactions. So it's not up here, but in the sort of dashboardy, more interactive version, there's a chance to sort of address people's predictable sort of responses. So we're trying ways of getting the content across in hopefully that will more actively lead to more directly lead to action. We talked a fair bit about Kevin. There's Kevin. So that's the guy that we've done quite a lot of work with in the primary care space, by which I mean sort of what you guys would describe as GPs. We tend to describe as family physicians. And he's led a trial recently where the Public Health Ontario, sort of the similar organization of that UK-based letter, but in our jurisdiction, sent out a notification to outlier physicians saying, hey, you know, you're an outlier. Get your act together. And we sent actually 2 different letters, one focused on duration. So Karen presented earlier some information that there's an opportunity probably to nudge down the duration of prescriptions given, because for most conditions, we can get away with less than a week, frequently 5 days or fewer even for pneumonia. And in the other letter, it was simply about, you know, don't even initiate. So we're trying to understand what's the most actionable metric through this approach. And then we did have a control group as well, because we needed to show to the funder the impact. And so that's a sense of what the letter looked like. And you can see we worked really hard to get various folks engaged. There isn't a person that carries the sort of credibility as you know, the lead of the public health agency in the UK. We try to accomplish that by having a bunch of logos, basically. But it's difficult, you know. I think the credibility, the opinion leader thing is probably important, but there, you know, like if I signed it, as I said before, that it's not really helping. So we got a few different folks to sign up from different organizations, trying to head that off at the pass. And so you can see what we did there. And then you can see the idea that we tried on the one hand to give information from Choosing Wisely about, you know, only initiate in these circumstances. And on the other hand, we gave information saying, you know, you really want to keep the duration short. And we'll be able to let you know soon whether that worked. If you had invited me 3 months from now, I could tell you. What we can tell you is that we've heard back from folks who received these letters. So we sent out thousands of letters, and a few people sent us back some information saying, yeah, and they did the predictable thing. They said, you know, my patients are different. A few people said, geez, thanks for sending this to me. I had no idea I was an outlier, that blew my mind, but it was very few. It was 10 people out of like 6,000. So, you know, let's not read too much into that. And then a very small number opted out. They said, what are you doing? Where'd you get this information? Get me off your list. It's like what I do when I get a robocall asking if I want my air ducts cleaned. So that was kind of interesting. It definitely gave us some idea that we needed to do more around the case mix adjustment, because in that letter, we didn't case mix adjust at all. And it is absolutely true that the people we sent the letter to have very high volume practices. So we know that those who see a lot of patients are going to prescribe more antibiotics, and they're going to prescribe more per capita as well, but we didn't adjust for that. We wanted to keep the metric simple, and basically they called us on that. This slide is to highlight one of my other collaborators. His name's Ben Brown. He's just had twins. He's at Manchester. And he's developed something called the clinical performance feedback intervention theory. And the CP FIT, as we lovingly call it now, helps one think through the different things that might impact how people respond to audit and feedback, and hopefully helps us design it better. If you see down in the bottom right, there's this stage called verification. That's what's going on when Joanne says, yeah, but the data's no good, or, you know, my patients are different. And that's what Nick exactly is trying to address in his intervention, trying to get people past that spot there where they might just say, this is crap, I'm out of here, and try to keep moving them around the loop towards acceptance, intention, and hopefully some change in their practice. But I want to highlight that change in practice is not easy. There's been a fair bit of qualitative work around this. It's an emotionally fraught situation. Clinicians have misperceptions about the expectations of patients that need to be addressed. That is to say, typically the studies show, to my knowledge, that patients want something to help them get better, or they want reassurance, and typically clinicians read that as they really badly want antibiotics. And so we need to do something probably in our interventions to address that. There's also the issue of time. You know, I think there are some studies showing that it doesn't actually take that much longer to communicate that, you know, you don't need antibiotics. Here's what you can do instead, yada, yada, yada. But physicians really feel it will take extra time. And when they're rushed, they prescribe. And we see that because prescriptions at the end of the day, the rate is much higher than at the beginning. So that's one clue. We also see it in high volume physicians have higher prescribing rates because they're just not, you know, they don't feel they have the time. So there's probably a role for us doing some skill building, not knowledge building. They know the right thing to do. It's a skill building exercise that we need to do around fitting this in to the time that they feel they have. So with all that in mind, we've been thinking about what's likely to have worked with that first letter that Kevin helped us set out and what we might still need to do to shift behavior. And so we're starting to develop a next round of letters that would come from Public Health Ontario. And our goal in the next round will be to address the things that have come up so far and really try to build bigger impact. And again, keeping with the theme that I've talked about before, try to test multiple ways of doing this because we don't just want to improve antimicrobial prescribing. We want to learn how to change prescribing so we can address it, you know, for the next issue. So our plan is to test different kinds of indicators, different kinds of comparators within the letter. I'll show you what that looks like. It's kind of like a factorial trial with a small control group. Basically, the plan then is to send 2 letters. So starting beginning of next flu season. So for us, that's like a year from now. And then another one a few months later, incorporating a bunch of sort of talking tips. This idea of like, try saying this, try not calling it bronchitis, call it a chest cold. People know that colds don't deserve antibiotics. A lot of people feel like bronchitis does, as an example. And so what we want to do is change some of the content. So we're hoping to test whether including content about harms, and somebody raised the idea of harms earlier, might make the benefits and risk the issue around risks of antibiotics a little more salient. So in particular, there's been a trial where I believe it was in Washington State. They sent information to prescribers of opioids, data saying, hey, in the last year, 3 of your patients died that you prescribed opioids to died because of narcotic misuse. And you can bet that worked. It worked real well. We can't exactly give a similar thing with antibiotics, but we can still talk about harms and highlight those ones that you're likely to cause if you keep prescribing these ways that are avoidable. So we want to test some language around that, and we'll do some user-centered design work before we send it out. And the other thing we want to test is the idea that, you know, when Joanne talks about, you know, my practice is different, I have some ideas that one of the ways we might get around that is by saying, you know, you're not just an outlier in general. You're an outlier compared to practices that are just like yours, with patients just like yours. So if we can use data and give some content saying something honestly like that, I wonder if it might attract a little more action. So we're going to test it and we'll find out. So one of the things I would point out though is then when we're testing small tweaks, small content changes in an overall intervention, we need large power. We're not expecting like just, you know, adding a little content about harms to make a massive difference in prescribing. And as a result, we need large sample size to have the power necessary to see the difference in terms of how we design the feedback intervention. So working with a large organization like Public Health Ontario offers us that opportunity because we're going to send this out to 9,000 docs. When we do that, we're already thinking, what'll we do in 2021 and 2022? And one of the things that comes up that I wanted to suggest as well that we haven't fully thought through is, at some point, some people are going to improve and some people are not. And we're going to be able to see that in the data. And thinking about how we tailor an intervention to improvers and to non-improvers, help the improvers focus on the next thing to keep improving, and help the non-improvers actually take some beginning steps of action, could be really, really interesting. So that's 2022 probably, and we'll keep iterating. So that's kind of what we have laid out over the next number of years, we hope, in large part led by Kevin. And I'll be sort of standing on the sidelines, helping with the trial methodology and hopefully raising the funds for it. So that's pretty much what I wanted to cover.
So any questions for Noah?
Don't all talk at once.
Yeah, I'll put a few down. Go around it.
Okay.